Good evening. My name is Jason Frischer, and I'm here with Lyndsey Jackson. And on behalf of the Cincinnati Children's Hospital Colorectal Center, we'd like to welcome you to our live chat on the management of Hirschsprung's disease in infants and children. We're hosting tonight's event because we've been hearing that families are interested in learning more about the management of Hirschsprung's disease. Like I said, my name is Jason Frischer, and I'm the director of the Colorectal Center here at Cincinnati Children's Hospital. I came here in 2008 from New York, and it's been a really growing experience for me. Lyndsey?
My name is Lyndsey Jackson. I'm a pediatric colorectal nurse, and I've been with the Colorectal Center for 8 years. Prior to that, I worked inpatient GI and colorectal nursing for about 1.5 years, and I just really enjoy working with this patient population and helping to improve their quality of life.
The Colorectal Center here at Cincinnati Children's Hospital is really the first of its kind and truly unique. We use a collaborative experience using pediatric surgeons who are specialized in colorectal surgery in conjunction with other specialties, including gastroenterology, motility specialists, urology, gynecology, our neurosurgical colleagues, and especially our radiology colleagues, because we do a lot of imaging on patients who require further investigations.
We are very excited about the large number of you joining us this evening, and feel free to start submitting your questions now, and we will get them queued up to answer. Please enter each question only once, and Dr. Frischer and I will do our best to answer as many questions as we can within the next hour.
So we're going to start queuing up the questions right now. There are a number already in place, and we're really excited. We know that over 300 participants have signed up and registered for this event, so we hope we can get to all the questions as best we can. So the first question we have is regarding nutrition and patients with Hirschsprung's disease. So I know Lyndsey has a special interest in this and will like to maybe make some comments on nutrition and how that affects patients with Hirschsprung's disease.
Sure. So many families want to know what foods their child should or shouldn't eat if they have Hirschsprung's disease. And some patients we find are very sensitive to milk or dairy products, and so sometimes by process of elimination you can see if that will affect your child's stooling pattern, or whether or not their abdomen is distended or bloated, how well they do tolerate other foods can be affected by dairy products. So that's a thing to consider. There are some foods that in general, for the general population, tend to be more constipating, and those are generally your white foods like white bread, white rice, white pasta, bananas, apples without the skin, and white potatoes. And so those are things that not necessarily your child cannot eat, but things that you want to sort of limit. And when your child does eat those, also ensure that they're eating other high fiber foods that tend to help them to go a little bit better at the same time to kind of counterbalance that constipating effect.
Another question I'm reading is, just started my son on solids and his number of stools went from 3 per day to 1 per day. Is this normal? What should I look for with starting solids that can be cause for alarm? Well, it is normal as you progress in your diet from infancy onwards and go from baby foods to more solid foods. The stools are going to become more solid and the number or frequency of stools will decrease. So that's normal. Our biggest concern for all patients with Hirschsprung's disease is making sure that you're not, even if you stool every day, that you may become more full of stool and becoming impacted with stool. And those are the concerns that we have. And the best way to look for that is if there are any signs or symptoms of constipation, meaning, is your child having abdominal pain or cramping issues? And the only way to really tell if you're becoming full of stool is to get an abdominal x-ray to look to see if there is stool building up within the colon.
Mm-hmm. Yeah, and so the goal for our patients is they have at least one bowel movement every 24 hours. So with transitioning to solid foods, one bowel movement per day could be a child's new norm. As long as they're not straining, the stool isn't very hard, and like Dr. Frischer mentioned, they're not having any abdominal pain or cramping, lots of gas, bloating, those kinds of things.
The next question, my baby, 8 months old, stools several times a day. Is this an indicator that he will stool often in the future?
Not necessarily. When a baby is 8 months old, they're eating much more frequently, and every time you eat, you stimulate the gastrocolic reflex, which will make you more apt to have a bowel movement at that time. And so as the child's feeding times get spread further apart, and as we mentioned with the previous question, they're eating more solid foods, the frequency will probably decrease. And so you just want to, as they get older, you want to start watching for a pattern. And if you are continued to be concerned, then you would want to check with your child's provider to see if there's any other cause for concern. So we believe that all children with Hirschsprung's disease that had a good operation should have bowel control. And so if the question is, I have an 11-year-old that was diagnosed at birth, he had about 3 inches of his colon removed. Today he experiences frequent leakage, and we are using liners to keep his underwear from getting soiled. Now that he is headed into middle school, we want to be able to help him reduce the leakage. And so really the leakage shouldn't be present at all. If there is leakage, there are things that we want to look for. We want to check first for constipation and rule that out with an abdominal x-ray. We want to look to make sure that his anal canal is intact and that it's not the sphincters weren't overstretched during surgery.
The real crux of this question is when you have a patient with Hirschsprung's disease that's after an operation and they're not doing well or having complications after the surgery, I think it takes a systematic and a logical approach to figure out why this is happening. And so typically your provider will do a number of tests and an extensive workup to try to investigate why this is happening. There are a number of reasons why a child could be soiling after Hirschsprung's disease surgery. And so this requires a workup that usually involves imaging studies, either x-rays and or a contrast enema to further investigate the anatomy of the colon and the significance of how much constipation there may or may not be present. And then there's other technical issues that associated with the surgery may influence patients who have constipation or leakage, which are the most common complications, or I don't know if complications is the right term, but issues following surgical procedures for Hirschsprung's disease.
Yeah.
Another question is a sensitive gag reflex related to Hirschsprung's disease, and what about acid reflux? So I'm unaware of a gag reflex being related to Hirschsprung's disease. As far as acid reflux goes, if it's purely acid reflux, I don't believe it's related to Hirschsprung's disease. But that being said, patients with Hirschsprung's disease do have motility issues and may affect the upper GI tract. What happens more commonly in patients who have poor appetites or bad reflux is the patient or is your child constipated and suffering from signs? Is this one of the signs or symptoms of the constipation? And it's being called reflux. And so obviously an abdominal x-ray would help rule out significant constipation, which may be the cause for bad for reflux. We find that patients just in general, if you're able to treat their constipation, have much better appetites and do much better with their meals if they're successfully treated.
Yeah. So there's another question. Can you give some pointers on potty training a child with Hirschsprung's disease? Really, the general concepts for potty training are the same for patients with Hirschsprung's disease. You want to have them close to a bathroom, give them frequent reminders to go to the bathroom. We generally recommend that we have the patients go to the bathroom in the morning when they first wake up, and at least try to go. Again, after each meal, just sitting for a few minutes because your body is more apt to go to the bathroom after a meal or have a bowel movement after a meal. And then again before bedtime to go and try to have a bowel movement. In between those times, if the child experiences any cramping or any sense of fullness near their bottom, then we also recommend that they sit at that time as well. Another key thing is just to make sure that they're not constipated. So if they are constipated, that's going to make the potty training process very frustrating. They're going to have a difficult time emptying it and sitting for long periods of time, things like that. So just working closely with your provider to make sure that when they do go to the bathroom, they're able to empty efficiently because they're not constipated.
So there's a question on, with one child with Hirschsprung's disease, what is the risk for siblings to be born with Hirschsprung's disease, and any news on genetic testing? That's a great question. It's a field of intensive investigation right now. Many centers throughout the United States are participating in what's called the HDRC, or Hirschsprung's disease Research Consortium, and we're looking at genetic testing right now. The testing is being run out of Johns Hopkins University, but many centers are participating and can help you with genetic testing, and we're looking and trying to learn more about genetic testing. The number for an exact percentage of if you have one sibling with Hirschsprung's disease, what is the chance of another sibling? We don't really know for sure, but it's approximately about 1%. So it's a pretty low number. That being said, you should certainly consider speaking with a genetics counselor, because some centers, and especially in Europe, are testing for some genes specific to Hirschsprung's disease, and that's what we're trying to study here, and especially through this Johns Hopkins consortium on trying to get more information on genetics and its relationship to Hirschsprung's disease.
So there's a question about a 4-month-old that continues to have some level of blockage and had enterocolitis, continues to be readmitted to the hospital. Is this to be expected? So even after surgery for Hirschsprung's disease, a child can have enterocolitis episodes, especially up to 1 year of age. They're more likely to have them. But with a good rectal irrigation protocol, you should be able to get the enterocolitis under control without being admitted to the hospital or needing to be admitted. If the patient is having frequent episodes of enterocolitis, we would probably look to see if there's something going on. We would probably want to do a contrast study and potentially do another biopsy.
Let me chime in for a second, Lyndsey. I think you make a great point. Having surgery for Hirschsprung's disease does not eliminate the potential for developing enterocolitis. But if it becomes a common feature that is consistent, then you should make sure your surgeon is aware of this issue, and then they may want to consider further investigations. Like Lyndsey said, some imaging studies, and maybe even rebiopsying or an exam under anesthesia to make sure the anatomy is okay. There are issues with strictures and twists and anatomic issues that may be discovered by the surgeon that might be the cause for enterocolitis, but is certainly a known entity after surgical procedures for Hirschsprung's disease to still develop enterocolitis. Another question is, what is the rationale for continuing dilations until the first year of life? I think that's a surgeon or institution-specific protocol. The usual rationale for doing dilations just in general is to treat a stricture or a narrowing of the anastomosis, or where the pull-through is connected to the very distal end of the rectum or the anus. And so dilations help stretch that connection or that anastomosis. When we do the surgery for Hirschsprung's disease, the anastomosis or the connection is a circle. And we know that when all wounds heal, they contract. If you cut yourself on your arm, the wound contracts. The same holds true for when you do an anastomosis and the circle contracts and narrows. And so the rationale for doing a dilation is to lessen or prevent that narrowing or stricturing of the anastomosis. For Hirschsprung's disease, typically it's less often needed than some other coloanal type of anastomoses, but it's often required, and so that's specific to the surgeon, but that's the rationale behind dilations.
If we do have to start a patient on dilations that we've operated on, we typically do about a 6-month protocol. We follow the same protocol as we do for our anorectal malformation patients. Correct me if I'm wrong.
Yeah.
And so we would dilate twice a day until the child reaches the goal size, and then decrease that frequency of how often they're dilating until they're completely weaned off, and that takes about 6 months. There was another question about a 5-year-old that had surgery for Hirschsprung's that has still soiling issues, and will the child ever be able to be continent and feel when he needs to have a bowel movement? And so, as we mentioned before with a previous similar question, children with Hirschsprung's disease should be able to have bowel control. It's just a matter of figuring out if there are any other issues going on that are contributing to their inability to feel when they have to go. Some of the things that we find with patients that have had ongoing soiling for a long time is that they sort of get desensitized to when they have a full rectum, because there's always something there. And so if we can eliminate that for children that are younger and less aware of their bodily cues, we may recommend daily enema for 3 to 6 months, and that helps the child to be clean and enjoy being clean and get used to what that feels like. And then they're much more motivated to stay clean when we stop the enemas. They're a little bit more aware of what it feels like when their rectum is full, so that they can go to the bathroom as soon as they feel that sensation. And they're a little bit more mature because they've been doing the enemas for a few months. And so that is helpful for some patients.
Just to tag along on that, and I agree with everything you said, is when your child is having issues, and not all patients with Hirschsprung's disease should have the potential for bowel control, meaning there are 3 basic concepts to having bowel control. You have to have this sensation, and so patients with Hirschsprung's disease should have this sensation, but there are issues that may affect that. The patient should have a sphincter or the muscles to control the bowel movements, and obviously there's surgical procedures that occur down there, and they may affect the sphincters, and then they have to have good motility. And that, we know patients with Hirschsprung's disease have motility issues with their colon. And so that's where our work with our gastroenterology colleagues help try to investigate and delineate why some patients have problems with Hirschsprung's disease and some don't. It's a complex problem and it's not simple, but if your child is having issues at age 5 or at the time of potty training and seems to be off the usual progression for children of that age, then it's getting it investigated.
Yeah.
The next question, can long-term stimulant laxatives use cause one to become dependent on them? I like to say, when I talk to families, and we get asked that question a lot, the use of laxatives and dependence, I consider when I talk to families that when patients are diabetics and they require insulin, they're not dependent on it because they developed a chemical dependency for the treatment, but they're dependent on them for their treatment of their disease. Mm-hmm. And so diabetics require insulin to control their blood sugars, and patients who are constipated, whether it's a Hirschsprung's patient or for any other reason, who require a laxative or some agent to help mechanically move their bowels, requires that to help successfully empty the colon. I don't know if you have any other thoughts on that.
I agree with that.
Next question.
My child refuses any food with cholestyramine. Is there any way to help reduce soiling? Or stooling, sorry. So usually when a patient is started on cholestyramine, it's because their provider has tried many other things to decrease the frequency that they're having bowel movements and have been unsuccessful in getting the number of bowel movements to a low enough number. And so if you've tried things like constipating diet, fiber, water-soluble fiber, and Imodium, and your child is still stooling too frequently, then colostomy would be your next option. There are many different ways to give a child colostomy. You can mix it with some liquid, you can mix it with yogurt, applesauce, pudding, but if none of those things are working, then I would first check in with your provider to see if there's anything else that you can do, such as increasing the Imodium dose, increasing the fiber dose, and then if those things aren't working, maybe checking in with someone who can further investigate the motility. As Dr. Frischer mentioned, we work closely with our GI colleagues with the motility testing in patients that we're really struggling with.
The next question, are there any resources to support parents as a couple and families with children with Hirschsprung's disease? That's a great question. We find that for families, it's great to have medical people and nurses and doctors and caregivers try to give support and help, but helping each other is always a great way to help with that. And so we support a Facebook page that sort of tries to engage families in discussing issues with each other. But there are some organizations, two that come to mind off the top of my head is the Pull Through Network, and the other is REACH, both parent-run organizations that work with patients with Hirschsprung's disease and offer support outside the medical field, and they're very useful and helpful organizations. Next question. Is it possible to manage a newborn with dilations only, so we can wait until the child is older to fly to Cincinnati, or do they need surgery as soon as possible?
So generally, patients with Hirschsprung's disease need to be operated on soon so that they can prevent a life-threatening episode of enterocolitis. When we have a patient that we're scheduling for surgery and it's not going to be immediate, we have them do rectal irrigations by our protocol at least 3 times a day, every day until the time of surgery. So I don't think that dilations alone would be enough to keep the child safe until surgery could be completed. But if you are doing rectal irrigations effectively by our protocol, the child should be able to wait a certain period of time until surgery can be performed.
I think that's an important question, and thanks for asking it. I agree with everything Lyndsey says. The part about dilations is really not, you're not dilating the rectum. The rectum is of a normal, or anus is of a normal size in patients with Hirschsprung's disease. What you're doing is stimulating the rectum, or doing a type of stimulation to help evacuate the stool. We know one of the diagnostic signs of Hirschsprung's disease is if you do a rectal exam, you get an explosion of stool out. And I think that's what's being done if you're encouraged to do dilations per se for a patient with Hirschsprung's disease prior to an operation. I think you have a few weeks to try to treat it, to delay the operation, but I don't think you have months to years. We typically don't encourage that. And really the key to waiting those couple weeks to having a Hirschsprung's operation is irrigations. That's the, if there's one thing we could teach every family that's watching tonight, is to learn how to do a proper irrigation. We have that on our website. So if you go to the Cincinnati Children's website and go to the colorectal page, you'll find a video on how to do irrigations, and that's an important piece of information that we could share with you. I think it's important also to know that the operation for Hirschsprung's disease does not definitively cure you of getting enterocolitis later in life. So it's something that knowing how to do irrigations is just extremely important, and we ask that you watch the video and learn how to do this, and ask your providers to help you with this so that you have the supplies and the know-how to treat your child if this situation should arise.
The next question, my child has been getting ear infections and placed on antibiotics. Will this lead to enterocolitis? And certainly anything that affects the bacteria or the flora in the intestines could set your child up for enterocolitis. So taking antibiotics, some children that have a virus, even a respiratory virus, can lead into an episode of enterocolitis. And so some families find that it's helpful anytime their child is on an antibiotic or has some type of virus, and to give them probiotics or to feed them yogurt, specifically a yogurt that says on the container that it contains live active cultures, because not every commercial yogurt has the right cultures to help protect you against things like that. So that's something that could be helpful. I would recommend talking to your child's provider before giving them something like probiotics, because they're not necessarily right for everyone. So you just want to make sure that it's appropriate for your child.
The next question states that my 4-year-old stools during the night. What can I do to help him stay clean overnight? And so that's a question, a great question, and many families deal with this type of situation. I think it's important to make sure that you are not, this sounds like a problem or an issue with one of two things. One, it could be a problem that the child is constipated and having some overflow issues associated that can especially occur at night. And is the child on other medications such as Miralax or laxatives or something that's overstimulating that child's colon or rectum? It's really a child-specific reason of why that may be happening. So like a simple x-ray might help elucidate whether the child is severely constipated and having some overflow issues, or maybe there are other issues involved. But clearly if they're continent during the day, they have the mechanisms in place to be continent, and it might just need some tweaking or work to try to overcome that issue.
Mm-hmm. So the next question is, Hirschsprung's disease a lifelong condition, or is it considered fixed after successful surgery? So Hirschsprung's disease is something that we consider a lifelong condition. You definitely want to always be mainly concerned about constipation and effectively emptying the colon so that you don't stretch it out, which leads to more constipation and could lead into soiling concerns. Generally, we find after about a year of age, the incidence of enterocolitis is less, but there's always potential for enterocolitis. And so you always want to be looking out for signs of that, distension, diarrhea, fever, things like that. And like we mentioned previously, when you're ill for another reason, it could potentially lead into an episode of enterocolitis.
Next question is right along those lines. Do adults with Hirschsprung's disease require specialized GI care? And if so, how do I find a qualified doctor, since most experts are pediatric surgeons? And my surgeon died in 2000. Well, you probably had a great surgeon, because it sounds like you're doing well. But I don't think you require specialized care. First of all, there's lots of pediatric surgeons that will see adult patients, especially at larger medical centers. All pediatric surgeons, or just about all pediatric surgeons, are adult trained surgeons as well, so we're qualified to take care of adults as well as children. But it might depend on the hospital and the rules and regulations. But I think most GI doctors can handle the adult situations, which primarily would be constipation by that time. There's very few patients that really deal with enterocolitis when they're in adulthood. Those issues have been dealt with beforehand. So it's really the long-term constipation issues. And that brings up another issue, which isn't asked, but we're working on, is what are the long-term outcomes for patients with Hirschsprung's disease? No one has really studied this. We always talk about immediate post-operative issues and some issues with bowel management, but the long-term outcomes haven't been dealt with. And I think the pediatric surgery community is now starting to tackle those issues, and hopefully we'll have more information in the future.
Next question is, what are the best remedies for constipation? So first, you want to make sure that it really is constipation. So abdominal x-ray, contrast enema, those kinds of things will help you to know whether or not the child truly has constipation. And then we find that a stimulant laxative tends to be most effective. Many patients that we encounter have taken stool softeners in the past and have had limited success with them. We find that the stool softeners tend to soften the stool, and then it may leak out throughout the course of the day, but it doesn't help them really empty their rectum effectively. So a stimulant laxative such as Senna, which is what we use typically, so that could be in the form of Senna syrup for little children, or X-Lax chocolate squares for older children, or even the tablets. That really helps the colon and the rectum to contract and empty more effectively.
Next question. With a Hirschsprung's patient, what are the risks of using a motility inhibitor to control bowel movements? That's a great question, and one where we struggle, because the bigger question is to make sure that your child actually has what we call a hypermodal colon versus a hypomodal colon. What I mean by that is a hypermodal colon is a fast-moving colon, and the stool evacuates quickly, and then that's where you'd find the opportunity to use a motility inhibitor, versus a hypomodal colon, which is a constipating colon, but you could still have diarrhea and accidents from that, because you could have what we call pseudo-incontinence or overflow incontinence, where the stool is backing up, and then the liquid stool, either caused by a stool softener or just by diet or whatever reason, causes leakage of stool around the impacted stool that's already present in the child's rectum. And so before using a motility inhibitor, I'd make sure that you actually have a hypermodal colon. Mm-hmm. And then second, and I think what the basis behind the question is, you don't want to make a colon too hypomodal or slow it down too much, because there's thoughts that enterocolitis is caused by stool stasis. Mm-hmm. And so you want to make sure that you're not causing too much stasis. And that's where working with your caregivers in a way to make sure that you're not backing up too much with stool. Typically, we use x-rays to confirm that you're not being impacted or having impaction of stool, is a way to monitor that. If you're using motility inhibitors, and we use the Imodium or other agents in patients with Hirschsprung's disease, but it's definitely less frequent than patients who require laxatives or agents to help provoke bowel movements. So it's safe to use motility inhibitors. It just has to be in the right situation and monitored.
Yeah, and one thing that I would think about if your child is having gurgling from gas, it could be that the child actually isn't emptying well enough, and then there's trapped gas. So you just want to make sure that you're treating the right problem in the right way, and that's something you can work closely with your provider on. The next question is, what are the signs of enterocolitis to watch for? So typically it's abdominal distension or bloating, and they can have explosive diarrhea, they can have fever, they can have decreased appetite. In some cases, they don't stool at all. And so usually with a child with Hirschsprung's disease, if you have any of those symptoms, if you notice one or more of any of them, the first thing you want to think of is it could potentially be enterocolitis. And so we tell our families, if you notice a fever and diarrhea, or a fever and not stooling at all, then just go ahead and do an irrigation. And we tell them that they can do them 3 times a day until the episode has cleared up, meaning they're back to their normal diet, normal activity, acting like themselves, no fever, for at least 24 hours, and then they can decrease the frequency of irrigations or stop them altogether, depending on the specific scenario.
I agree, and I think, like I mentioned earlier, if there's one thing we could share with everyone watching and participating in this, is to watch our irrigation video and to learn how to do irrigations and have the equipment to do irrigations, and you could talk to your care providers about this, so that, because the treatment of enterocolitis can be life-saving, and so it is extremely important that the families understand how to look for the signs and symptoms of enterocolitis. So it's a great question, and then also know how to treat it, because many practitioners, especially adult practitioners in small community facilities, may not really know how to deal with enterocolitis. It's not that common of an event that a small adult urgent care or community hospital might not be as versed to treating this, and knowing how to do it yourself will be the best treatment for a patient who maybe develops enterocolitis. And we always say, if you have concerns that your child might have enterocolitis, it's always safer to just perform a irrigation and then communicate with your caregivers or practitioners so that you get further guidance and treatment as necessary. So the next question, is genetic testing of family members medically necessary for Hirschsprung's disease if a child in the family has already been diagnosed and had surgery? So I don't think we're at the point right now to say it's medically necessary to have genetic testing. Like I mentioned earlier, I think in many European countries they are doing genetic testing on most patients who have Hirschsprung's disease. Not so true in the United States yet. There are open studies being done looking at the genetics of Hirschsprung's disease, but it's not, as of right now in the United States, a medically necessary part of the treatment of Hirschsprung's disease.
A question, does having HD or Hirschsprung's affect the immune system? My son seems to get sick more often and more severely. I don't know if Hirschsprung specifically can affect the immune system, and maybe Dr. Frischer can piggyback on that, but I do know that a lot of your immunity is in your colon, and so if you're not emptying well or your child is having, some low-grade enterocolitis that's ongoing, that can affect their immune system potentially. But I don't know if in general.
I don't think there's a direct link per se, but I agree with you. The immune system is the largest of the components of the immune system, or one of the largest. Your skin is a large component as well. So if your intestine, large or small, is affected with Hirschsprung's disease, and we know that Hirschsprung's disease, we only know the tip of the iceberg of what really means to have Hirschsprung's disease and the neuroenteric components of what Hirschsprung's disease consists of. And so is there a relationship? Yes, there's probably a relationship. We just don't understand it well enough to say there's an exact problem with the immune system. Right. So that's my answer. The next question is, I noticed that my son can control opening and closing the anastomosis or stricture. Is that normal? I'm not exactly sure what that means, but children with Hirschsprung's disease should have control of their anal sphincter. And so if the sphincter isn't injured or there's not a congenital malformation or whatever the situation might be, but it has a normal anal canal and normal sphincters, then they should be able to control their anal opening and have continence that way.
The next question, what is the hope for a child with total colonic Hirschsprung's and an average rectal manometry test to be completely continent? So the philosophy that we have when treating patients with total colonic Hirschsprung's disease is that we like to wait until the child is potty trained for urine before closing their ileostomy, and that they will be able to accept rectal irrigations in the event that they have an episode of enterocolitis. Because we have seen many patients that had their ileostomy closed at an earlier age that have ended up with extreme diaper rash to the point that it can scar. And so we feel if they're potty trained for urine, then they're already comfortable with sitting on the toilet. They can already verbalize or communicate to their family members that they need to go to the bathroom. And so they're much more apt to have their bowel movements in the toilet and less likely to have a severe diaper rash. And so if we wait until the opportune age around potty training, then their potential for bowel control and having bowel continence is the same as a patient without total colonic Hirschsprung's disease or with a shorter segment Hirschsprung's, but they are going to go much more frequently. And so the key is to eating foods that are going to help them have thicker stool and potentially be on motility inhibitor that we were talking about earlier, fiber, and all these things will help make the stool more formed and help it be more likely for them to be able to feel when they need to go.
The next question, what do you recommend to prevent diaper rash due to smearing or soiling? And Lyndsey, I'm going to leave that one to you.
Well, I mean, the first thing that I think of is, why is the child smearing or soiling? Because they should be able to have bowel control after Hirschsprung surgery. And so in the meantime, while we're figuring out why they're smearing and soiling and working on that, things that we use are Sensicare, anything really with zinc oxide in it. I think most over-the-counter diaper creams carry that nowadays, so you want to look for zinc oxide. Typically, if you can keep the area dry during the day and allow air to it. So during the day when they're awake and they can be closer to the bathroom and get cleaned up sooner rather than later, just keeping nothing on it really so it can heal. And then at nighttime, then I would definitely keep something on it so that they, if they have any accidents during the night or any smearing during the night, it prevents that contact with their skin from the stool.
Next question. My child has total colonic Hirschsprung's disease and was given a pouch at his surgery. He's on many meds now for frequent pouchitis. Is this lifelong? Is surgery to remove the pouch something we should look into? It depends. I assume you're referring to a Duhamel pouch, although there are some patients with total colonic Hirschsprung's disease that received ileal J pouches by some surgeons. And so it depends. It's just an interesting question of what type of pouch. But that being said, patients with total colonic Hirschsprung's disease are certainly harder to control their stooling, and so medications are more often required. But pouchitis, if the patient is having pouchitis, then you have to make sure you investigate, is there an anatomic issue with the pouch? So a rebiopsy is often indicated, a contrast study to look at the anatomy of the pouch, and usually a scope or a flexible sigmoidoscopy to investigate the appearance of the pouch is important. And if all things fail, that we've certainly removed pouches for patients who are struggling severely. It's a big surgery, and we've had good success if that is deemed the right therapy at the end. But it takes a long and extensive, or a very extensive workup to make sure it is the pouch that's causing the problem and not some other reason that might be causing the issues with the pouchitis. The other thing that is tried sometimes, and this also depends on the type of pouch, is diversion. So getting an ileostomy or diverting the stool for a while to let the pouch calm down and be treated, and then trying again to try to improve the outcome with the pouch. But it depends on the anatomy of pouch, how long, if it's a Duhamel pouch, how long is the segment of the aganglionic colon that remains there, because pouches are made to cause stasis. And unfortunately, that's tried to improve the stooling outcome or functional outcome of a patient who had Hirschsprung's disease surgery, especially for total colonic Hirschsprung's disease. Pouchitis is caused by stasis, so you have a double-edged sword. You're trying to have a better functional outcome, but the stasis is then causing inflammation or pouchitis. And so it's a difficult problem that requires a thorough investigation, but there is the opportunity or potential that removing the pouch may change the outcome for your child.
The next question is, what is the process for determining if a Hirschsprung's child would be a candidate for a cecostomy? And so, as we have mentioned, a child that had successful surgery for Hirschsprung's should be able to have bowel control as long as they're on the right bowel regimen. If they have constipation, we're treating that. If they move too quickly, we're managing that. That being said, if we do our workup and we find that the patient's sphincter was overstretched at the time of surgery, or if their anal canal, which is the area where they sense when they are about to have a bowel movement, if that area was damaged or is missing, then they have less potential for bowel control. So that would be a patient that would require a daily enema to achieve social continence. And in that situation, we would then say that they would benefit from a cecostomy so that they can become independent in their care. But certainly the cecostomy is not the treatment for a patient with incontinence. You first have to find the right enema for that child, and then that enema can be given independently through a cecostomy.
Right, so the cecostomy is just a route for the treatment of the situation. And so you could give the enema transanally or transrectally, and cecostomy makes it a more friendly or independent route of administering that in children who are deemed necessary to have that type of therapy. The next question, I am a 45-year-old female, not me, that's the question. I was diagnosed with Hirschsprung's disease when I was 2 weeks of age, and that was in 1970. I have a permanent colostomy. Is this still a common outcome? I think that's not a common outcome, especially if you have a colostomy and you have part of your colon brought up. We typically are able to, in the newborn period, perform a pull-through procedure for Hirschsprung's disease. And so patients who have longer segment Hirschsprung's disease or difficulty in the diagnosis of other comorbidities may require a colostomy for a temporary period of time. But typically, we're able to perform a pull-through procedure for Hirschsprung's disease at some point. So it is not common and something that still may be investigated to change the anatomy, your anatomy, and if you do have a colostomy, there's definitely the potential of bringing that colon down as a pull-through. And so I don't know all the specifics, but there's definitely the potential there.
Yep. The next question is, does Hirschsprung's have a neurological component? Are there any neurological correlations known, such as stuttering? I'm not familiar with any, but I will defer that question to Dr. Frischer.
As far as I know, Hirschsprung's disease is a neuroenteric disease, so involving the neurologic or neuronal component of the bowel or enteric system, and I'm not aware of any association with other areas. So as far as I know, there's no association. The next question is, are there any side effects to long-term use of Pectin? I'm going to leave that to Lyndsey.
We're not aware of any. We've been using Pectin for before I joined the center, which was 8 years ago. I know they were using that and when they were in New York as well. And so I think the only thing that I'm aware of that is something to be cautious of is we did have one patient that I've been aware of in the last 8 years that was taking the Pectin dry as a powder and not mixing it with anything. And they had a large amount of it that caused an obstruction. And so the child did get admitted to the hospital locally, not here at Children's, but they were observed at their local hospital for a couple of days. Did not require any surgery that I'm aware of, but that's just something we don't recommend that you take it dry. We always recommend that it's mixed with some kind of food or beverage, and doing that should not lead to that kind of issue.
Pectin makes jello.
Right.
There we go. The next question, is there any link or connection between Hirschsprung's disease and IBD or inflammatory bowel disease? I'm a parent diagnosed with Crohn's 6 weeks after the delivery of my Hirschsprung's disease child. So as far as I know, there is no connection between Hirschsprung's disease and Crohn's disease, other than both affect the enteric system or your bowels. Inflammatory bowel disease can affect anywhere from your mouth to your anus, but it's not a neurologic disease. It's an inflammatory disease or a disease of the immune system and inflammation, versus Hirschsprung's disease, which is a disease of the neuroenteric system or the nerve cells or the ganglion cells, as many of you know, and it's presence within the colon or small intestine. And so as far as I know, and I treat both Crohn's disease and Hirschsprung's disease, the odds of having both are extremely rare, and that's just a natural phenomena of the two diseases, so they are not related.
The next question is, my daughter's Malone was placed 2 years ago. She is now 11. Do I need to change the size of the 8 French Coude catheter based on her age or weight? if we are not experiencing any issues, do I keep the same size? And so we keep the same size for as long as the child will be using them alone. They should always be able to use an 8 French. The only time that we would use a different size is if it becomes difficult to get the 8 French in. We would then advise that you put in a 6 French, but typically not long term. We would want to see the patient in the clinic and see if we can get the 8 French in, or maybe dilate that Malone tract in interventional radiology, because we don't want it to continue to get smaller. And so that's just something to be aware of. If at any time an 8 French becomes difficult, you want to put it in and leave it in, tape it in place, and let your provider know that you're having difficulty.
So I think the issue with the only benefit of increasing size for a catheter in the Malone is that the larger the diameter of the tube going into the Malone, the quicker you could deliver the contents that you're infusing through the Malone. But infusing a very rapid amount of fluid is not good for the patient or the child for a number of reasons. It's uncomfortable, it could stretch the colon. So there's really no benefit to increasing the size of the catheter. The big risk or concern is stricture or narrowing of the Malone. That's probably the biggest complication we have with Malones or appendicostomies. And so increasing the size isn't necessary, but if you find you're decreasing in size, then there's concern for stricture, it may need attention. The next question, can the ileocecal valve contribute to constipation or motility issues in long segment Hirschsprung's disease? And so most patients who have long segment Hirschsprung's disease have the opposite issue of not constipation but hypermotility. The ileocecal valve does not contribute to constipation. So constipation involves the forming of solid stool and filling of the colon and inability to empty the colon. The ileocecal valve is the area where the ileum meets the cecum, or the first part of the large intestine. And so the stool in the small intestine, typically in a patient where we're not trying to solidify the stool for certain reasons, is of liquid nature, and the colon's main job is to absorb water and convert liquid stool to solid stool. So the ileocecal valve just controls the passage of liquid stool into the large intestine, but does not contribute directly to constipation per se.
So the next question is, how long are irrigations and enemas necessary? And so first I would say that it's important to understand the difference between an irrigation and an enema. An irrigation is given, which you can see on our video, is giving small amounts of saline and allowing the saline and stool and gas to come out. And you do this until the belly is flat and the patient is comfortable, versus an enema that you're typically giving for constipation or incontinence of stool. You're giving a large volume of saline at one time, allowing it to sit in the colon for several minutes and then expelling it all. So an irrigation should not be necessary for a long period of time. If you're needing to give your child frequent irrigations for an extended period of time, then you would be wanting to work with your child's provider to see if there's something else going on. Either a retained Hirschsprung's bowel left from the surgery, or a transition zone bowel, a kink or stricture that could be causing them to have enterocolitis symptoms. A daily enema would be necessary for potentially for a lifetime if a child does not have the components of bowel control, meaning that their sphincter was stretched during surgery, or their anal canal or the sensing mechanism was damaged.
Another question, my daughter underwent her pull-through surgery at 9 months of age. Now she is 21 months of age and weight gain is small. She's having very loose stools and stomach is always bloated from eating anything. Any suggestions on what food to eat? This is very concerning, and I think that there's a number. I think it's not what type of foods to eat per se. I think you should be concerned and question your providers on what are the issues, and is there a anatomic or any other problem that might be going on. There's certainly patients with Hirschsprung's disease have issues with allergies, especially to milk product, I think. So that could be part of the issue, and that needs to be investigated. But the small amount of weight gain over the course of a year is very concerning and requires sort of urgent attention.
Yeah, the difficulty gaining weight and the loose stools and bloating make me think that there's some sort of low-grade enterocolitis that's been ongoing. And so that would be something that I would be working closely with your provider on to figure out what's causing her symptoms.
Because a patient after a successful surgery for Hirschsprung's disease should grow just like any other child of the same age. Now, if a patient has long segment Hirschsprung's disease or total colonic Hirschsprung's disease, there are fluid and electrolyte issues that might be dealt with. But the growth should be monitored, and we should be able, with all our techniques, be able to treat that patient and able to have normal growth. So that's a issue that I would get addressed and definitely of concern.
Mm-hmm. There was a question, what age should I start my child on probiotics? We certainly don't start every patient on probiotics, and there isn't a specific age at which we do start it. I think that would be a more specific question for your child's pediatrician that you work with as to whether or not probiotics would be beneficial or indicated or appropriate. And then they also may be able to guide you as to which specific ones to use for your child.
The next question is there a test to determine true incontinence from pseudo-incontinence? Yeah. There's a workup to try to determine that. And so typically pseudo-incontinence is due to constipation or impaction of stool, typically in the left colon and rectum, with overflow of loose stool. And so x-rays and contrast enemas help to determine that. That being said, you must ensure that you have all the mechanisms in place to be continent, and then therefore you could determine if you have true incontinence. What does that mean? That means you have the proper muscles in place, you have a good sphincter, you have the anal canal is intact, what Lyndsey sort of alluded to earlier, in that the nerves that sort of control liquid, gas, and solid and know how hard to squeeze is located all in that area. And so making sure that that is in place and present will help you determine whether you have true incontinence or pseudo-incontinence. So it takes a little bit of a workup, an examination, and some imaging studies to try to tease out true incontinence versus pseudo-incontinence. Mm-hmm.
The next question is, what issues makes a child with Hirschsprung's a good candidate for a bowel management program? And so we think that any child with Hirschsprung's disease that is not having at least one bowel movement per day in the toilet at the age that his or her peers are doing the same thing should be on a bowel management program. So whether it's laxatives or enemas or just diet, all those children should be managed by someone, and making sure that their bowel management program is effective for them specifically, because there's no cookie cutter bowel management program. It's all tweaked based on each child's needs, and it's something that takes trial and error and dedication between the providers and the family.
I see a question, is intestinal atresia within the Hirschsprung's disease spectrum? Small intestinal atresia has not been associated with Hirschsprung's disease, but there are a few patients of the rare instance of colonic atresia, and there has been an association of patients who have had colonic atresia and Hirschsprung's disease. And so patients with colonic atresia should be screened for Hirschsprung's disease. And it looks like we have the last question of the night.
Yes. Hirschsprung's babies and children continuously receive x-rays when being treated at the hospital. Shouldn't we be concerned about the amount of radiation they receive at such an early age? And yes, of course, we are concerned about the amount of radiation they receive. And outside of our bowel management program, where we're getting daily x-rays for a week to try to get the child on a good regimen, we try not to get frequent x-rays, but some are needed periodically to ensure their success. several months ago, our radiology department did a study, and they calculated all the radiation that a typical patient that goes through our bowel management program will receive during that time, and that's including all the contrast enemas and a couple other studies that our Hirschsprung's patients don't receive, plus the daily abdominal x-rays during that week. And that was about the same amount of radiation they receive if they were just living in the city of Cincinnati for, I think it was 3 months. And so it's, if you take it into the grand scheme of things, yes, it's a concern, but it's also a concern to make sure that the child is healthy and successful with their bowel management routine, because it impacts so many other areas of their life.
I think it's a great question and a good point, and something we always keep in the back of our mind, but we use it when appropriate. Yeah. And I think if you outside of Cincinnati Children's Hospital, if you go to pediatric hospitals and pediatric radiologists, they will also limit the amount of radiation per x-ray. Mm-hmm. So it is 8 o'clock, and we'd like to, on behalf of myself and Lyndsey and the entire Colorectal Center here at Cincinnati Children's, we want to thank you for joining us this evening. We hope you found this session informative. In the next few days, we will provide you with a link of the recorded event. Please call us at 1-877-881-8479 for more information about our program. And thank you very much for joining us, and this was really informative and fun.
Thank you.